Hello everyone, welcome to the IPDLN session on trauma and violence. My name is Melissa Willoughby and I'll be your chair for this session. In this session we have three very interesting presentations. They'll run for about 10 minutes each, and this will be followed by 15 minutes of questions and discussion. If you do have any questions during the presentation, please go over and head them in and put them into the Q&A box. And we'll be answering these questions at the end of the session. Our first speaker today is Mr. Bernard Leckning. Bernard's work has focused on the health, well-being and health service outcomes of vulnerable young people and adults, especially those at risk of suicidal behaviour. He has a strong commitment to and is experienced in working with Aboriginal and Torres Strait Islander people on these health and well-being issues. He has experience in epidemiological and evaluative research using community surveys and administrative data. He is currently completing his PhD investigating the outcomes of hospital-treated self-harm and suicidal thoughts in the Northern Territory, and manages a repository of linked administrative data supporting the Northern Territory Child and Youth Development Research Partnership. So handing over to you, Bernard, looking forward to your presentation. Would you like to share your screen?
Yes, thanks, Melissa. Thanks for that introduction. I'll just share my screen now. Okay, hi everyone. And firstly, I'd like to acknowledge the Indigenous peoples from the lands where we're all gathering virtually here today, and I'd like to pay my respects to their elders past, present and emerging. Secondly, I have to apologise, but unfortunately, Helen Milroy is unable to join us here today, which is really unfortunate. You're stuck with me, but we'll be discussing this research that we were involved in, investigating the risk of self-harm by young Aboriginal people with a history of child protection involvement today. So, the links between the history of child maltreatment and subsequent self-harm are well established, and we know that this risk persists well into adulthood. Most of these studies rely on self-report data, which we know can be subject to some recall bias, but most importantly, quite often these studies lack fairly precise information about the timing of these events, as well as the kind of responses to these events, both bits of information which can be helpful to sort of informing more effective prevention and intervention. Responses to child maltreatment in most countries are established in legislation and the responsibility of statutory agencies, which in Australia we refer to as child protection services. Now, there are very few studies that have examined the association between child protection involvement and self-harm, as they tend to rely on administrative data where there's very limited information on other risk factors, and there's the threshold for statutory responses and the way the data is often captured doesn't tend to accurately represent the risk that's carried by exposure to these adverse events. So I guess the thing is that population data linkage is well placed to address these challenges, but I guess the most important thing to note is that it's increasingly recognised that child protection involvement is an important opportunity for prevention. That's especially so in the Northern Territory of Australia, where I work and live, where rates of both self-harm and child protection involvement are amongst the highest of any jurisdiction in Australia. And this is particularly so for the original inhabitants of Australia, who identify as Aboriginal and Torres Strait Islander people, and who make up about 30% of the Northern Territory's population. In Australia, Aboriginal and Torres Strait Islander children are experience about 6 times the rate of child protection involvement and twice the rate of self-harm compared to the general population. And these, I guess these concerning levels of child protection involvement and self-harm are actually a fairly recent phenomenon that are attributed to, I guess, seen as contemporary effects of intergenerational trauma caused by European colonisation and history of racist policies that have entrenched disadvantage in the Aboriginal and Torres Strait Islander population, especially in relation to historical genocidal policies that forcibly removed Aboriginal children from their families, resulting in what we call today the stolen generations. Now, in recognition of these social and historical influences, recent parliamentary inquiries in the NT into child protection and youth suicide have recommended broad-scale public health approaches to prevention. However, there are no studies that involve Aboriginal and Torres Strait Islander children, and there's very little evidence that helps to clarify the opportunities for prevention for Aboriginal and Torres Strait Islander children. So to address these gaps in the evidence in the NT and more broadly for Aboriginal and Torres Strait Islander children, we developed a retrospective cohort data linkage study using the repository established as part of the Child and Youth Development Research Partnership here in the NT. It comprises linked de-identified unit record administrative data from health, education, welfare and justice agencies for about 145,000 children. For this study, we focused on Aboriginal children who were born in the NT between 1999 and 2003, just to help maximise follow-up in the data that we have available in the repository. We only included children who had at least one record in our repository after 10 years of age, just to help minimise any bias due to censoring. And we excluded children, missing Indigenous status, perinatal records, or who were born to mothers residing interstate. Now, the outcome for this study was measured using first hospital admission, including an intentional self-harm diagnosis in adolescents. And we were interested in two sort of dimensions of the exposure. So the level of child protection involvement was measured as no involvement, and then notifications, which refers to reports made to the Child Protection Service regarding maltreatment or risk of maltreatment. And then we have substantiations, which are notifications that are investigated by the Child Protection Service and where they found evidence of maltreatment. And then lastly, we have out-of-home care, which refers to children with substantiations that are then removed and placed into alternative care arrangements. Now, we were interested in the association with self-harm based on exposures in different periods of childhood. So looking at early childhood, so 0 to 4 years of age, and then middle childhood, 5 to 11 years of age. We used survival analysis techniques to follow up individuals from their 12th birthday until the outcome was observed or they were censored. We estimated cumulative incidence, so just to give us a sense of the proportion of the population with self-harm by 18 years of age. However, for this presentation, I'll focus, on the results of the multivariable regression analysis, where we used Cox models to estimate the relative risk of self-harm by level and timing of child protection involvement. And here you can see how we've modelled the different levels of exposure for regression. So we're looking at the combination of different levels of involvement. And sorry, I should note that we collapsed out-of-home care into substantiations just because the numbers were too small for reliable estimates. So we're looking at levels of involvement across a combination of early childhood and middle childhood, which gives us this kind of 9 levels of exposure, and hopefully the little shorthand there in the table makes it easier for you to kind of look at the results that I'll be presenting in the next slide. So here we have the results of the analysis expressed as adjusted hazard ratios. You can see it on the left-hand side of the graph there. For the combination of child protection involvement in early childhood on the right there on the Z-axis, and middle childhood, which is on the X-axis there. So I should point out that these estimates are adjusted for socio-demographic characteristics and confounding perinatal risk factors. The bolded columns that you can see in this 3D graph highlight estimates where there's strong evidence of an association with increased risk of self-harm in adolescents. The reference category for the analysis is shown in black there. So you can see at the bottom right-hand corner of the graph, that's children with no involvement either in early childhood or middle childhood. So if you kind of start there and work your way back towards the sort of top left-hand corner of the graph, what you can see overall in the pattern of estimates is that there's generally a kind of increasing risk of self-harm associated with increasing level of child protection involvement right across childhood. But that's particularly the case for children with substantiated child maltreatment in middle childhood, which you can see in the bars on the very left of the graph there. And in particular, children with substantiations in both early and middle childhood are around about 8 times higher risk of self-harm in adolescence compared to children with no involvement with child protection services at all. So the results overall paint a picture of cumulative harm relating to child protection concerns throughout childhood being associated with an increased risk of self-harm in adolescence, but in particular when these exposures culminate in substantiated reports in middle childhood. Now, these results are fairly consistent with calls from Aboriginal people for closing the gap on Indigenous disadvantage overall, which we know kind of underpin child protection concerns, self-harm, as well as a range of other adverse outcomes. It reinforces the need for early intervention and prevention programs. There are a number of promising trauma-informed and culturally responsive parenting and family programs. Reform of child protection services, we can see that there are some promising models of therapeutic programs for Aboriginal and Torres Strait Islander children sort of involved in the high levels of child protection services, but there's a gap in regards to the culturally safe assessment of Aboriginal and Torres Strait Islander children that should be informing decisions made by the Child Protection Service. So hopefully we can see here how population data linkage helps to bring together all this information around the timing, the level of involvement, and these particular kind of rare outcomes for particularly vulnerable population groups, and how it can help paint a better picture of those outcomes and the opportunities for prevention. There are definitely gaps in data around the provision and quality of services offered that would help to improve further research in this area. I just want to thank, investigator team and the partners to this research, and Helen, who's unfortunately
Sorry,
not
Bernard,
here,
I was going to cut you there. That's your time. Thank you so much for your presentation.
Thank you.
That was great. Thank you so much. If anyone has any questions for Bernard, can you please pop them in the Q&A chat, and we'll answer them at the end of the session. Moving on to our next speaker. The second speaker today is Carol Orr. Carol Orr is a PhD candidate at the University of Western Australia. She uses linked administrative data to investigate the health and social outcomes of children exposed to family and domestic violence. So handing over to you, Carol, can you please share your screen? Whenever you're ready, Carol.
Sorry, it wasn't letting me share my screen. Apologies.
Okay, no problem.
So good morning. My name is Carol.
Sorry, Carol. We can't see your screen. Do you want to try resharing it?
Yeah.
That's great. We can see it now. Thank you.
Oh, thanks. Yeah, so good morning. My name is Carol Orr, and I'm a research fellow at the University of Western Australia. And our study looked at the impact exposure to family and domestic violence has on children's early development. In Australia, family and domestic violence is the term used to describe violence that encompasses intimate partner violence, and for Aboriginal and Torres Strait Islander peoples, violence between extended kinship ties. The term family and domestic violence should not detract from the fact that women and children are disproportionately affected by violence perpetrated by men. Therefore, our study focused on family and domestic violence perpetrated by men against women. So, children's exposure to family and domestic violence includes witnessing and hearing the acts firsthand, as well as the effects of living in the aftermath of the incidents. So the children could see their mother with broken limbs, the house could have damage, holes in the walls or damaged furniture, or indeed the child may have to flee the home with the mother due to the violence. The most recent personal safety survey in Australia highlighted that most female victims of family and domestic violence are assaulted in their own home, with 50% of all female victims having children in their care at the time of the assault. We know that young children are particularly vulnerable to exposure to family and domestic violence due to the time they spend in the family home. While the outcomes of women who are victims of family and domestic violence are well documented, the literature on the outcomes of children who are exposed is lacking, with these children being referred to as the forgotten victims. So what we aim to explore was if children exposed to family and domestic violence have greater vulnerability in early development outcomes in their first year of formal schooling. So our study is a retrospective cohort study using linked administrative data. We identified children born 2002 to 2010 who were exposed to family and domestic violence from birth to 5 years of age. We used data from the Australian Early Development Census, which uses the Australian version of the Early Development Instrument, to capture a measure of early development in children in their first year of full-time school. Since 2009, the instrument is completed by teachers and is collected every 3 years. The instrument is a population measure of developmental competencies covering 5 domains of child development. That is physical health and well-being, social competence, emotional maturity, language and cognitive skills, and communication skills and general knowledge. So originally, we identified the exposure to family and domestic violence using West Australian police data from 2004 to 2008, where the mother had been a victim of family and domestic violence perpetrated by a male that resulted in that male being charged. However, due to the widespread issue of family and domestic violence, we interrogated our non-exposed cohort. So originally we had matched 3:1 of exposed to non-exposed, and we interrogated our non-exposed cohort to look in our non-exposed children to see if any of their mothers had hospitalisation records for family and domestic violence. And what we found was that 2% of these children in our non-exposed cohort had a mother who had been hospitalised for family and domestic violence. So those children were recategorised into the exposed cohort. We used multiple data sources from government and non-government departments, and these were linked by the West Australian Data Linkage branch. And as you can see on the slide, we had data sets such as birth registrations, disability data sets, and police data. We merged the data sets, which provided us with information about the children, such as their mother's age, as well as information on the child's gestation period and their socioeconomic status. We had just shy of 1,400 children in our exposed group and 5,500 in a non-exposed comparison group. Logistic regression analysis was used to calculate odds ratios and 95% confidence intervals for developmental outcomes of children exposed to family and domestic violence compared to children not exposed. Adjustments were made for characteristics known to increase the risk of developmental vulnerability, such as sex, socioeconomic status, Aboriginal status, mother's maternal age, mother's marital status, gestational age, disability, birth year, and their remoteness. So what we found was that children exposed to family and domestic violence were more developmentally vulnerable in all 5 categories. So children exposed to family and domestic violence have a 58% increased likelihood of being vulnerable in physical health and well-being. And this includes challenges that interfere with their ability to physically cope at school, such as being frequently late, being hungry, and having poor gross motor and fine motor skills. You can see the exposed children also have a 58% increased odds of being vulnerable in social competence. And this includes challenges in getting along with or playing with other children, following rules, or having low self-confidence. The exposed children also had a 66% increased odds of vulnerability and emotional maturity, and this includes anxiety, aggressive behaviours, and hyperactivity. The exposed children also have a 42% increased odds of vulnerability in communication and general knowledge. This includes difficulties in talking to others, understanding and speaking English, and having poor general knowledge. You can see in the last domain that exposed children have a 69% increased odds of vulnerability in language and cognitive skills, which include challenges such as difficulty remembering things and that they are uninterested in trying reading and writing at school. So to further investigate the impact of family and domestic violence on children's outcomes, we grouped the developmental domains, and we found that children exposed to family and domestic violence are 70% more likely to be vulnerable in 2 or more of the developmental domains. And the children are 90% more likely to be vulnerable in all 5 domains compared to non-exposed children. Our findings show that exposure to family and domestic violence increases the odds of vulnerability in all 5 domains of child development. Children exposed to family and domestic violence are more likely to be vulnerable in multiple domains and outcomes compared to the non-exposed children. The findings further support that children's exposure to family and domestic violence is an area of public health concern. Because we looked at children exposed in the early years, 0 to 5, and it's their first year of schooling, we have opportunities for intervention. Furthermore, we identified these children through police data and hospital data, which gives us further areas for intervention. The educational outcomes of these children identified warrant further investigation. I'd like to thank the people of Western Australia for use of their administrative data and thank our industry partners. Thank you very much.
Great, thank you, Carol. Another fantastic presentation. If anyone has any questions for Carol, could you please go and put them in the Q&A box and we'll get them at the end of the last presentation. Now moving on to our 3rd and final presentation for today, I'd like to introduce Dr. Marcelo Urquia. Marcelo is a research scientist and assistant professor at the Manitoba Centre for Health Policy at the University of Manitoba. He obtained a Bachelor in Anthropology at the University of Buenos Aires and a Master of Public Health at the National University of Langes at Argentina. He received a Master of Science with the Institute of Evaluative Services and the Della Lana School of Public Health at the University of Toronto. He holds a Canada Research Chair in the Applied Population Health. Thank you, Marcelo. Handing over to you.
Thank you very much, Melissa. Well, my presentation focuses on the risk of violent injury, including violent death, after episodes of intimate partner violence among women who have been identified as victims through the justice system. Basically, prosecutions and sentences. Yeah, since this material is unpublished, I will ask you to refrain to tweet the main results. Thank you. Why doing a study on this topic is using administrative data is also important because of the fact that intimate partner violence varies substantially according to the definitions and data collection approaches, right? For example, surveys capture most cases, even mild events and false positives, but the justice and healthcare systems usually capture more severe cases of IPV, right? Those requiring police intervention, the mediation of courts, and medical attention, right? So we are looking at the extreme of the more severe cases. So then justice identified intimate partner violence may be a predictor for healthcare utilization due to violence. So we restricted the study to women, adult women in the province of Manitoba from 2004 to 2016. So in the data linkage, the spine is the provincial registry that has information on all the Manitoba residents with provincial healthcare coverage. And then the justice databases were linked to this registry. So the justice databases include the prosecutions and dispositions, also known as sentences, and included information on the victim and the accused as well. So, and on the side of the outcomes of injury, we looked at hospitalizations, emergency department visits, and also on violent deaths. Because the justice system doesn't identify directly IPV episodes, but they do have a flag for domestic violence. So in order to separate intimate partner violence from domestic violence, we use family information, family relationships from the provincial registry to exclude events where the victim was a parent, a child, or a sibling of the accused. And then we retain records where the accused was a male who may be a spouse, common law, or dating partner of the victim. So that's how we narrow down to IPV. And then for the outcomes, we use standard international classification of diseases codes. So we use a match retrospective cohort study design. We took the women's first IPV victimization to ensure that all women had no history of IPV in the past 2 years prior to this victimization. and we paired that woman to 3 other women with no known history of IPV. And they were matched on age, region of residence, and relationship status, mainly whether they had a spouse or not. So we used conditional Cox regression and did some stratified sensitivity analysis. So the main results show that victims of IPV as identified in the justice system have about 4 times the risk of subsequent injury and death than non-victims of IPV. And that is after adjustment for a number of covariates, let alone those used in the matching procedure. So we also looked at the subset of intimate partner violence victims to look at some predictors among the different characteristics related to the victimization episodes. And we found that, for example, if the victimization episode involved physical violence, the risk of subsequent victimization was greater, 74% higher. We didn't find an association according to whether the accused was convicted of physical violence, but we also found an association if the accused was a youth. Youth is defined as less than 18 years old. Interestingly, if the accused received a probation sentence, the risk of subsequent victimization decreased almost by half. So this is using any intentional injuries, including hospitalizations and emergency department visits as an outcome, but we repeated these results restricting to hospitalizations only, because the capture of emergency department visit is not perfect and varies across the province, so hospital data is much better, and we found basically the same patterns. The differences between these results are minimal. Yeah, so we have some limitations. For example, this lack of completeness of emergency department visits. We also restricted, for the sake of simplicity, to female victimization and male accusation. And these results are not generalizable to male victimization or other gender couple relationships. We couldn't include ethnicity in these results, although in a rerun we are including immigration data. But unlike justice data, the healthcare data doesn't provide information on the perpetrators, which is a big limitation because we don't know whether the subsequent injuries were caused by the same perpetrators of the original intimate partner violence episode or not, right? And finally, some misclassifications in healthcare data may happen if intentional injuries are misclassified as unintentional. Well, we know this is domestic violence is a complex problem. Using data linkage to explore these issues has the potential to advance the field, and also to promote some intersectoral dialogue and collaborations. For further intersectoral studies, it will be important to do some studies restricted to some minority population, such as indigenous groups or some immigrant or ethnic minorities.
Thanks, Marcelo. Sorry to interrupt you. I'm going to have to call time there. Thank you very much for your presentation. Okay, so that includes all of the presentations for today. I can already see we have some questions for our presenters in the chat box. If you have any more questions for the presenters, please add them in. The first question we have is for Bernard. Bernard, thanks for the great presentation. There are two questions in this one. The first is, are you able to account for the type of child abuse on self-harm outcome? And the second question is, would the lack of emergency data, i.e. by only using hospital data, underestimate the rates of self-harm?
Yeah, thank you. Thank you everyone for those presentations, and thank you for that question. Short answer is yes, we would be underestimating self-harm in the population by not including ED. We know that probably only about 30% of self-harm in the community makes its way to the hospital. However, I think Marcelo's kind of already half answered this question. The recording of things like injury is variable in ED data, and we undertook a clinical audit study in 2013 of ED presentations that we could identify involving self-harm and suicidal thoughts, and found that the data appears in lots of different places. There's no standard in Australia for recording self-harm in ED, although that's coming, and there's some really interesting work happening in Victoria. There's some interesting studies that were undertaken by Matthew Spittle, if I recall correctly, in New South Wales. So we're hoping to, when we will be getting ED data, and we're hoping to develop an algorithm to more accurately identify self-harm in ED, and we can undertake that study in particular. The second question, which was about the type of abuse. Yeah, we had to make a decision with a rare outcome like self-harm, even though this is a whole of population study. The Northern Territory is a very small jurisdiction. Whole population here would fit into a local government area in, you know, the capital cities of Sydney or Melbourne in Australia. So, you know, it's very difficult to do that kind of thing here, to look at multiple dimensions. So we had to make a choice, and we felt that there was a lot of evidence already around types of abuse. And so we focused instead on the timing, largely because we also wanted to focus on that question of what are the opportunities for prevention and whether there were any differences across those periods of childhood. But hopefully with the next version of the repository that we're building, we'll have data on mothers and children and a greater birth cohort. We'll be able to reinvestigate this question again with more data, and hopefully include a couple of other dimensions of exposure.
Great, thanks, Bernard. The next question is for Carol. Carol, this is a bit of a long one. The question's about your cohort definition. You said that you initially defined the exposed cohort using police records, and then it seemed you had an unexposed cohort matched 3:1 based on the characteristics of the exposed group. However, subsequently, you then used hospital data to add to the exposed cohort based on the hospital records of women's admissions. So my question is, the exposed cohort that was picked up by this additional method were only from the match sample of initially unexposed cohort you had. How do you think this addition of these women affected your results? Did you run a sensitivity analysis removing them? I wonder if most of your cohort being picked up by police reports and having a male charged for the offence is significantly different from the only hospitalised group. Did you adjust for the method of cohort entry in your analysis? So I think this person's asking about the two ways that you've measured family domestic violence injuries? And how this may have impacted your results?
Yeah, thanks very much for the question. Yeah, so yes, that's correct. That's what we done. So we did have an initial, our initial study was set up so that our exposure was identified through police data, and then we had mothers, we had maternal hospitalizations, and we had in previous data used hospital data to identify family and domestic violence. So we then looked at these children to identify the violence. When we effectively recategorised these children who were exposed in the hospital data, we did look at differences between the cohorts, and we noted that so to take a step back, in WA, about 7% of the population, the child population, is Aboriginal and Torres Strait Islander, and our population within our data was more, the majority was from Aboriginal and Torres Strait Islander background. And when we looked at differences between the police data and the hospital data, we did find that there was some differences, in particular that Aboriginal women had higher rates of hospitalisation contacts for family and domestic violence, even compared to the higher rates in the police data. So there were some differences within the two places that the women were accessing help from. And then obviously these differences flow through to the children's identification as well and their characteristics. When we did look, because there weren't, and obviously there is some crossover as well. So we have some people identified in both hospital and police data. Because of the sizes, because it was 2% were identified in the hospital data, and of some of them were identified also in police data. When we looked at it, no, we didn't find anything different, but that's not to say that that's not because of our limitations with numbers. I think that in the future there is a need for not a matched study like ours, but a whole of population data study, where we get all hospitalizations for family and domestic violence and police data as well. So yeah, while there is limitations from it, due to the small numbers, it didn't make that great an impact. It made no impact on our findings, but that's not to say that if we used whole of the population, that it might identify something a bit different.
Oh, thanks, Cara. The next question's for Marcelo. Marcelo, do you have any recommendations on how we can better record incidences of family, intimate partner violence?
Well, yeah, that's a tough question. Well, it depends in which context, right? This study, well, is tries to do a workaround based on administrative data. Yeah, so it is, well, the justice system is a good context to assess this issue because of the is very thorough and intensive, right? And there are many parties involved, from the police to the prosecutors to the judges to the witnesses, etc. It's a long process. So in terms of data collection, it seems like it's an excellent it's an excellent data source in terms of the quality of the data. However, it may miss many cases that don't reach to the police attention or the justice system, right? And that is something that needs to be supplemented with other means. Sorry, there is no perfect answer, right? That's why intersectoral collaboration may be the way to go.
Oh, thank you. It was a tough question. We're under 10 minutes left, so if anyone has any last-minute questions, please put them in the Q&A box. Bernard, a question for you. You're looking at quite a sensitive topic, or two sensitive topics, self-harm and child protection within Indigenous communities. I was wondering, have you involved the communities within this? How did you find, building relationships so that communities were comfortable with research being done on these kind of issues? And did they have any concerns?
Yeah, no, that's a really, really important question. Now, I guess what we have is, I'll try and quickly talk about our governance sort of structures for the work that we do. What we have an Indigenous health reference group made up of community leaders and people who work in health and who meet regularly to review and comment on research proposals. And typically we'll ask questions and comment on aspects of the study that have particular relevance to Aboriginal and Torres Strait Islander people in the NT. Now, I guess the comment we got back from this study was we really need to understand this. So there was really quite a sense that, yeah, we really want to know what's happening. It's a really tough and sensitive topic. And I guess so no other real comments other than, we just had to sort of really be quite sensitive and contextualize all the findings, which I guess what you've seen in the presentation, I spent a lot of time on, but more importantly, what we do is we involve Aboriginal researchers throughout our research. So if you know Helen Milroy, recently won the Australian Mental Health Prize, Australia's first Aboriginal and Torres Strait Islander child and adolescent psychiatrist, really well respected, and commissioner at the National Mental Health Commission. Tanya Havonen, who's a respected Aboriginal clinical psychologist and who is heavily involved around suicide prevention initiatives in both the Territory, Queensland and the national level, have been involved quite comprehensively throughout this research and informed the design, how we interpret the results. So I've probably not touched on a lot of contextual issues and how we need to address them, because that was probably the most important thing that we needed to focus on in particular was implications. But that's hopefully going to come through in the paper, which is currently now with the editor of Child Abuse and Neglect. So we hope that in the paper we talk a little bit more about that. But yeah, and certainly, Helen Milroy said that she was happy for anyone who had any questions about the work. If they wanted to contact her, then she was more than happy to talk to anyone about it from an Aboriginal and clinical perspective. Yeah.
Great. We're looking forward to that paper coming out. Good luck getting it published.
Thank you. Thanks.
Carol, a question for you. Do you think there are any implications from your research looking at the intergenerational cycle of violence? So the young people who you looked at who may have experienced violence themselves, then leading on to then perpetrating it themselves or experience future violence victimization?
Yeah, thanks very much for that question. Yeah, I think there are implications. So we've got more findings from the early development outcomes that I didn't have time to share. But what we did was we looked at specific behaviours in the children, such as them hitting and kicking other children or bullying other children. And we found that the children were more likely to bully other children, hit out and kick. And I think that the reason for that will be multifactorial. You know, the children are seeing that behaviour and copying it, or that they are trying to make sense of what's going on, and they don't have the skills to get along with their peers, and they're frustrated, so they kick out. So it could be multiple issues. I guess these behaviours, if intervention isn't put in place, that these behaviours will go on throughout their childhood. And I guess that, yeah, we do need to look further at these children, and I think that's where administrative data plays a key role. And if we can look, you know, keep continually looking at these children and then seeing what happens to them, you know, are these children in the future admitted themselves for family domestic violence or in police records for family domestic violence, or is it the flip side that some of the children are involved in justice service because you know, they're perpetrators of the violence? So I think that it is really unfortunate that the data on the outcomes of children is very limited, and it seems to be that, you know, we're gradually taking steps to have a better understanding. And I think that we just need to build on what we've got and continually look to see what's happening in the long term for these children.
Great, thank you. Just time for one final question. It's another one for you, Carol. May confounding by family level characteristics have affected the results?
Sorry, could you say that again, please?
May confounding by family level characteristics affected your results?
Oh gosh, I need to cast my mind back. So yeah, we had confounding characteristics. So yeah, so we had things like the socioeconomic status impacted, and we did find that you know, multiple characteristics did impact our results, and you know, we adjusted for many of them. What we found was for this one, I'm trying to think wider. So we didn't stratify our analysis by Aboriginal status in this study, primarily because of numbers. But we did find that our covariates did impact our outcomes.
Oh, thank you. Well, that concludes our session today. Thanks so much to all the panelists for their great and interesting presentations. And thanks for the delegates for attending this session. A recording of this session will be available on the conference platform for 24 hours. If you enjoyed this session, you may also be interested in today's featured on-demand videos and posted, and you can find these in the on-demand gallery. Thank you everyone so much for attending.